Hi guys, my name is Ashley. I'm currently a third year medical student, and I'm strongly considering going into anesthesia for my medical specialty. Anesthesia is a really great field, but unfortunately, I think a lot of students don't get very much exposure to it. It's not a required medical rotation at most schools, and so plenty of students will have to spend an elective on their clinical years of experience in order to get some anesthesia exposure. But how are you to know if it might be a good fit for you if you don't have any exposure? So, this lecture is designed to discuss some of the things you can expect to see on an anesthesia rotation and to go over all the pre-operative assessment type questions and exam. This lecture is going to be geared towards medical students, particularly second or third year medical students who are unsure how they want to use their elective rotations during their clinical years. But of course, anybody is welcome to listen and learn something about the field. The overall goals are to prepare you for the first week of an anesthesia rotation, get you some knowledge about assessing preoperative patient conditions, help you to review key physical exam components, what you want to ask your patient to do, and what you're looking for with why. And to So I'm going to go ahead and give you a few moments to look over the objective slide, copy anything down if you need to. These are going to be our goals for you by the end of this lecture. So oftentimes what people will associate with anesthesia is what they're most familiar with from either media, popular media, or tabloids. So for instance, the doctor down in the bottom right-hand corner is an anesthesiologist from Grey's Anatomy, or people might have heard of how Michael Jackson or other celebrities died in drug overdoses. In Michael Jackson's case, it was related to an overdose of propofol, which is a common anesthetic agent. In my experience so far, anesthesia isn't really like what either of these would portray it to be. It is a procedurally based field often. It tends to involve doing a lot of nerve blocks, line placements, catheters or A lines, difficult IVs, and intubations. And it's very satisfying because it requires a good amount of technical skill. You get to provide patient comfort and alleviate pain. You can work in a variety of settings. It's fairly hands-on and active. There's a lot of physiology and pharmacology to understand. Because one of the most important things about anesthesia is that it enables safe and pain-controlled surgical procedures to take place, I want to start with the things that you need to assess about your patient before the surgical procedure ever starts. So the first three things or groups of things that we're going to go over are going to be the ASA classification, pre-op questions that you always ask your patients, and the physical exam that is focused and relevant for anesthesia. So now I want to go ahead and talk about the ASA classification system. So this is a system devised by several anesthesiologists in an effort to better be able to describe and stratify the illness and expected complexity of patients before their surgeries. So this is something you might use in order to discuss how well you think a patient is going to fare. So the numbers range from 1 to 6, and as your number increases or your grade increases, the expected difficulty and complications increase as well. Class or grade 1 is a normal, healthy patient. 2 is a patient with mild systemic disease, and systemic means it affects multiple whole body organ systems. So something such as cirrhosis of the liver, while it would certainly be a threat to a surgical patient, it would make the recovery much more complicated. It's not a systemic disease. Similarly, like an intestinal perforation is another example of something that can certainly mean poor prognosis. It does not mean systemic, so just keep that in mind. So for stage 2, you might be talking about somebody with high blood pressure, which is a systemic disease, and it's well controlled. Stage 3, you're talking about a patient with severe systemic disease, so maybe high blood pressure that is not well controlled, or diabetes that is now has now led to retinopathy. Those would be examples of severe systemic disease. 4 is a patient with severe systemic disease that is a constant threat to life. 5 is a patient who is not expected to survive without the operation. So that is pretty much the lowest, or I suppose the highest risk you can have, because 6 is kind of a different class in its own way. It means the patient has already been declared brain dead, and at this point, the purpose of the procedure is to harvest organs for donation purposes. So now I'd like to go ahead and go through a couple of examples so you can get a little bit of practice using that ASA classification system. So in this first example, let's say we have this patient here on the left. She's middle-aged, has well-controlled hypertension, but poorly controlled diabetes type 2. What ASA grade would you assign her? We would go ahead and assign her a 3 because she has a systemic disease that is poorly controlled. So you need to include the biggest risk factor for this patient. Let's take another example. We've got this wonderful stock photo of a lovely jogger here. We'll say that she has advanced age, but she is healthy and is miraculously without medical problems. What ASA grade would you give her? We would assign this patient a grade of 1 because no medical problems and healthy mean low risk, and the advanced age is not something that we consider there in that ASA classification. Let's take a third example. We have our gentleman over here who has his asthma inhaler and his cigarette in his mouth at the same time thanks to the aid of Photoshop. We'll say that he has well-controlled GERD, but as I said, he's a current smoker, and his asthma is controlled, and he has not had any recent exacerbations. So this gentleman would get a score of 2 because of the current smoking status with the well-controlled conditions. Although asthma is not truly a systemic condition, the current smoker status, we're going to elevate him to grade 2 there. Now I'd like to go over important pre-operative questions to ask your patients, any patient, before they undergo a surgical procedure. So I will say that plenty of doctors and hospitals will have their own styles of asking these questions or doing things, but these are still overall pretty core pieces of information to find out about your patient before you take them to the OR. First off, you want to know, do they have any allergies to medications? Include in that or ask specifically about adhesives or tape, because you're going to be taping most likely an endotracheal tube into place around their mouth. You're going to be taping their IV line site. You might use adhesives during the procedure. So you want to know for sure if they're going to have a reaction to those. You're also going to want to clarify if the patient states that they had a reaction to something, what the reaction was. Because if they say, oh, I got a rash where my skin was sloughing off, we're going to react to that information very differently than if they had a little bit of nausea from a medication with a known side effect of nausea. That would mean it's not a true allergy. Another thing you're going to want to find out about is a personal history of complications from anesthesia. What was the complication? Do they know what medication or at least type of anesthesia induced that? Most patients aren't going to know, to be honest with you, but it's still worth asking because if you can get that information, that only helps you. Be very suspicious if they say that nausea and vomiting was their complication, again, because this is associated with a lot of anesthetics. It doesn't necessarily mean that they have an intolerance or an allergy to that medication. A little bit of post-op nausea and vomiting is common in plenty of patients. If they know, or if they don't, that's okay too. But if they know if somebody in the family had malignant hyperthermia, you do want to get that information. Malignant hyperthermia can be potentially deadly, which is why it's important. It's marked by rapid muscle contractions and a rapid rise. Another thing you're going to want to ask is, when's the last time you had anything to eat or drink? Make sure that their NPO status is intact. You don't want your patient to have eaten right before the procedure. This is really important to ask about, and procedures can be canceled over this because when the patient is under anesthesia, they could aspirate whatever is in their stomach. It can be sucked into the lungs, causing an aspiration pneumonia, which tends to be even more severe than most pneumonias. So that's a complication you do not want to deal with. Some of the guidelines that I've seen used are that it should be at least 6 hours since they had a light meal. For infants, 4 hours since they had breast milk, 2 hours for clear liquids. Again, all of these can vary depending on your hospital or your particular surgical procedure. Usually, small sips of water for essential medications are okay, but nothing more. Another thing you're going to want to ask about is review of systems. You don't want to take an ill patient to surgery, meaning they're ill with something that you can wait and it will resolve. So you can ask about chest pain, shortness of breath. Their baseline pain is also important to know. You want to know, are they going to be needing any extra pain control for this? Now, some places will ask about exercise or lung capacity lumped in with other breathing questions, so it depends on your location. But it's generally a good idea to know, can the patient walk 2 blocks or so without getting winded? Can they climb a flight of stairs and be able to breathe through that? If they say no, or that they would do it with difficulty, you're going to want to clarify potentially, is that related to something that could be a difficulty for me as the anesthesiologist, or is that something that is unrelated to the case at hand? For instance, maybe the patient can't walk very far because of lifestyle crippling arthritis, but they can actually breathe just fine and their cardiac capacity is fine. Those are very different types of scenarios to find yourself in. You're also going to want to ask about past medical history and surgical history. Uh, in particular, some conditions that you're going to want to know are poorly controlled systemic diseases. Those are some of the most important. So you're going to ask about congestive heart failure, MI, anything that could have happened with the heart, strokes, seizures, diabetes. If they have diabetes, what's their blood glucose like? You're probably going to check it anyway and verify, but you still want to ask. Kidney failure, are they dialysis dependent? This is also important because they're probably going to get a different type of IV fluid regimen, and you're going to want to be particularly careful not to overload these patients. You're also going to want to really make sure you ask about breathing history. Do they have COPD? Are they oxygen dependent at baseline? Do they have sleep apnea? Or they may not know that, so you're probably going to want to ask, has anyone ever told you that you snore at night? Do you find yourself waking up gasping for air? If they don't know the answer, then hopefully not, but you always want to just be cautious. So last but certainly not least in your list of preoperative questions, you're going to want to ask about social history. In particular, you're going to want to pay attention to drinking and drugs. Drinking, because we want to know, does this patient have any chance of being alcohol dependent, and do we fear alcohol withdrawal? Drugs, because we need to know what are their risk factors for infection, what's their background pain tolerance like, and what kind of pain control are they going to need. Um, do they have anything online in their system that could contribute to side effects or dangerous complications? Like if they use opioids, when's the last time they took that? Does it potentially complicate my case with respiratory depression? So we need to be very thorough in asking about this history. I've heard attendings approach this a number of different ways. Some will just ask, do you use any alcohol? If so, how much? Do you use any drugs? Anything not prescribed to you? I've seen others use more layman terms, such as, do you do any other drugs? Cocaine, heroin. They'll start giving examples to hopefully prompt the patient. They'll say, when was the last time you got high? So whatever it is that helps you get that history from the patient, that's an okay way to go ahead and ask. You should always do your best to establish trust with the patient to hopefully encourage them to tell you the full story. A lot of patients will be motivated if you explain, I want to be able to take the best possible care of you. I want to make sure I'm giving you appropriate medications and that nothing negative is going to happen if we can prevent it. I need to know what you're taking so I know what to give you and how to appropriately control your pain. Usually, if you're on the patient's side, if they feel like you're an ally to them, they tend to be a little bit more forthcoming with some of these more delicate topics. So now for the third thing on our list of preoperative assessments for a patient, the focused physical exam. So you're going to want to listen to the heart and lungs on every patient. For anesthesia, because your job is generally going to be something to do with putting a tube down to help that patient breathe during surgery, you want to pay attention to the neck and the TMJ range of motion. You want to know if you're going to be able to manipulate this patient's neck in order to place your tube and to visualize their airway. Can their jaw open wide enough for you to pass this through? You're also going to want to inspect the nares. And in the cases of some difficult patients or suspected difficulties with intubation, or you're worried about respiratory complications, more on that in a minute, you also want to inspect the nares for the potential to place a nasal airway. I had a patient just the Another part of your focus physical is going to be telling that patient to open their mouth and say ah for you. You're going to want to ask about broken or chipped teeth, anything that is removable. You do not want to chip a tooth, knock a tooth out, have them swallow it. Those are all big no-nos. And then you're going to want to evaluate their Mallampati score. I've also heard this abbreviated just the potty score, or people just discuss what class of difficulty they're going to be. So this is a scale that's used to evaluate the estimated difficulty for intubation on a patient, and it also serves as a proxy for the likelihood of that patient having sleep apnea. So when you have the patient open their mouth, you can just tell them, I'm looking to see if I can visualize all the structures here. And your ideal situation is going to be a class 1, shown on the left. This means that you can completely visualize the soft palate, and it's good because it means that you don't estimate any additional difficulty or obstructive tissues getting in the way when you go to place that ET tube. So that is your best case scenario. And it goes all the way up to class 4, which is a worst case scenario, where you have the soft palate not being visualized clearly at all. This almost certainly means that the patient has underlying sleep apnea. It indicates that obstructive tissues are probably going to get in your way. You can prepare for this by maybe having an additional assistant with some expertise on hand or another doctor. You can have a glide scope at the ready. These feature a blade that is designed for difficult intubations, and it often has a large screen equipped to it, so you can visualize the structures more easily. Anything you can do to be better prepared ahead of time will help you when you're. Since a good tool for preparation is practice, let's take a look at evaluating these two images for patient A and patient B and see what Mallampati score you think you would assign them. Remember that your options are class 1 through class 4, with 1 being the easiest and 4 being the most difficult because the soft palate is not well visualized. And then if you have a partner available to you, I would also recommend turning towards them, having them open their mouth, say ah, stick out their tongue nice and far, and visualize their palate and try to assign them a score. You can discuss whether or not you can agree through either using a mirror to look yourself or maybe taking a picture with a cell phone. So go ahead and pick out a score for patient A and patient B, and then the answers will pop up shortly. We would go ahead and assign patient A a class 1, so no additional difficulty with intubation is going to be suspected because we can clearly visualize the entire soft palate, and it means we're unlikely to encounter obstructive tissues. Patient B is going to be class 4. We can't see any structures on the soft palate. We expect a hard time, but we're going to have to do our best to make that patient comfortable during their procedure. Here's a quick recap of the objectives from this lecture. Take a look over them, see what you can remember, and feel free to go back to some of the earlier slides or content of this lecture if you need to. Thanks for listening to my lecture. I hope you feel a little bit more prepared to assess your patients if you decide to start an anesthesia rotation, and I wish you the best of luck.